Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can be profitable and successful for years to come. This week, I'm excited for our topic. I welcome Laureen Murphy, Chief Operating Officer of MedCycle Solutions and MedAcademy, a revenue cycle management company out of Minnesota. Laureen is an experienced healthcare revenue cycle and information management consultant with more than 30 years experience in various healthcare roles, including operations, administration, billing, coding, compliance, education, and patient billing. Oh my goodness. Laureen, welcome to the podcast.
Thank you so much for having me, Terry.
We're so happy that you're here, and especially with the topic today. The topic is something nobody wants to talk about, but they have to talk about it because, as you know, having a healthy revenue cycle includes talking to patients about their share of cost and financial agreements and ABNs with the patient population. And so this is where we're going to kind of have a conversation, or we are going to have a conversation, just talking about not just the components of it, but why they're important and what you can do to not just be successful at it. That word doesn't really describe it. I think it's more making sure patients understand that that is part of their health care. So, I don't think they understand that sometimes. And I honestly believe that COVID kind of messed us up a little bit with the public health emergency, allowing for so much, and I'm air quoting, free stuff. And then, and then now they're like, oh no, now you have to pay again, 5 years later. And so let me just start us off here. First of all, when we talk about a financial, agreement, let's say with patients, and when I say ABN, Advanced Beneficiary Notice, that's specific to Medicare. Patient responsibility. So patients do have, most of them have they're ultimately responsible for the balance of, what's owed that is offset by the allowable by the insurance company, their deductibles, their co-pays, and, as a courtesy, so the physician will, bill and the practice will bill it. But I think sometimes there's I don't know if it's misperception or misunderstanding about share of cost. And I wanted to turn it to you because I know we have to be careful with, balance billing. The No Surprise Act took care of that, but patients don't always understand their out of pocket, and especially with high deductibles and high copays even. What have you dealt with this?
So yeah, it's difficult because patients don't understand. So I think that the most important thing for a practice to protect themselves and also to build trust with the patient is to be transparent up front and have a good patient financial agreement. Your patient financial agreement serves as a clear understanding between the provider and the patient about the payment expectations. It'll talk about what the insurance coverage is and what the billing policies for the practice are. So some of the things that you need to make sure you have in your financial agreement are your practice information and also the patient information. You also want to make sure that it states that the insurance information on file is accurate and up to date, and it explains to the patient what their responsibility is, such as copays or deductibles, or even what's not covered by insurance.
Yeah, I find that sometimes you mentioned something as far as be clear. For example, in gastroenterology practices, they do screenings, and with, for example, cancer screenings, colonoscopies, and some of those services don't have a share of cost. The physician part of it, the anesthesia part of it, it's fully covered by Medicare, but there are frequency guidelines. So if you get into that where you don't tell the patient that, well, you've already had one in the last, 24 months or whatever, if you're high risk, then it could come back that you're responsible. Or if they do a diagnostic, let's say EGD, upper GI endoscopy at the same time as a screening, you're going to have a share of cost. And I think patients miss that, quite a bit, where yes, there may be one thing that you don't have an out of pocket. I think the biggest thing, and actually I was listening to a webinar on this the other day and I was getting a little frustrated because this is what bothers me. Maybe it bothers you too. I don't know if you've seen this, but it's a challenge for somebody that deals with revenue cycle management as we do. Patients that come in for an annual well visit or they come in for preventative. And it seems like more and more we're seeing that providers are consistently always billing that office visit with it. And
Oh, yeah.
yeah, and in the AMA CPT book, it clearly says if an abnormality is found and if you have to, you
Mhm.
know, work up the patient separate from the preventative, separate from the annual well, then, and if they even say if it's significant enough, I saw one that it was a pediatric patient. So a 12-year-old boy was having a preventative service. And he says that his shoes didn't fit well. He's telling the doctor this, and he noted it in the and in the wellness chart. And so he told him, well, you probably need to go up a half size. And he tried to charge a level 3 in addition to the visit for that. I'm like, people, can we not do that? A good friend of mine, you may know her, Christine Hall, who, yeah, she's a consultant out there. And her and I were talking. The doctor was telling her mom, who's in her late 80s, that you know, she was older, and she goes, I know that. And they try to charge, something to tell her she was old.
Oh my goodness. Oh
I
my goodness.
know. I'm just
Yeah,
like,
it's crazy because they use that as a revenue generator. But
I
what they don't
know.
understand is that it's it's just going to be a take back if they get audited,
Right.
you know, and just because they can get paid for something doesn't mean that they should be billing
Doesn't
it.
mean they
And they have to
should.
make sure that that documentation supports it, that there
Right.
is something significant and that they have that. So I always tell providers that when they're looking at something like that, is it something that you can separately document? Can you get another, if you had to document that separately in a separate note? I even think it's best practice to do a separate note if you're going to do a separate
Oh, I,
E&M.
I absolutely tell them they have to.
Yeah, yeah,
Well, the thing
100%.
that bothers me about it too is the fact that I see doctors. What the webinar I was listening to that was frustrating is there was a provider on there basically saying, well, we do it in reverse. We basically tell the patient that, they're coming in for a sick appointment, but while they're here, we'll do a well check. If they're coming in because they're sick, they're not well enough to do a well check. That's the
Exactly.
that's the stupidest thing I ever heard of. And I know that's probably not a
Yeah.
professional comment,
Yeah.
but I don't care. It's like, it's like
No,
this is a
you're
podcast. We can say
absolutely
whatever we
right.
want.
It's a complete oxymoron there. You can't do a well visit on somebody who's sick.
Who's
And,
sick? I know, right?
it has to be one or the other. So, and when I see practices trying to use that as revenue generators, and if they do that and they're charging that, then they're going to take a copay from the patient on that
Exactly.
office visit. Well,
Exactly.
then they get into once it's denied, if it's denied or if it's taken back, they've got to refund the patient portion of that within 60 days. So the administrative burden that it ends up being on the practice to end up being compliant with any of it, it's not worth doing it in the first place.
Yeah, you have to
It
be so
ends up
cautious.
yeah, yeah, it really does. And, I see that so often as well, Terry, and it really is a big point of contention out there because I have some providers that want to do it every single time.
Every single
That,
visit. Yeah.
yeah, yeah, exactly. Every single annual checkup, they will do an E&M with it. It's like they're finding a reason to add that additional E&M on.
Now, Laureen, I know you do a lot of consulting, as I do. How do you explain to practices that the conversation about money and about share of cost, about, the patient's specifics as far as what their insurance will pay, what it won't pay, especially again with these high deductible plans, how do you explain to them that the doctor really should stay out of the conversation? It really should be, well, that's my opinion. It really should be more of the, revenue cycle management staff, the administrative staff, and then the doctor's there to be a clinician. and we're there,
Exactly.
but then the doctor can't sabotage the the conversation then, because then they'll say, well, now I'm on a first name basis with the doctor. He told me I didn't have to pay
Yep,
my
yep,
copay, and it becomes,
exactly.
a nightmare there. So how do you have that conversation?
Yeah, I've been in that situation too. I come from a derm background, as do you. And when I was in dermatology, I would have people who would say to me all the time, "I'm a close personal friend of the doctor, and I'll just talk to her." The way that I present that is, I think that having these conversations in a pre-registration format is really important. Being transparent with the patients up front. You want to make sure that you're talking to your patients and being kind and using words that they understand. That's a big thing because when you start to talk about things like out of network benefits or medical necessity and things like that, it can go over a patient's head really quickly. They don't know exactly what you mean. So I think having these conversations in a pre-registration environment instead of waiting until the patient gets to the office, if you have these conversations at your front desk, first of all, there can be HIPAA concerns there, as well as you have the patient who is in a rushed environment and they're just going to say, oh, you know what? I'm just going to talk to the doctor about this. And then it gets to the doctor. But if you can be transparent and proactive and build that relationship with the patient in a pre-registration format, you're going to be much more successful and your patient's going to understand much better. Patients ultimately want to do the right thing. They know that there's cost associated with this. So if you have that conversation, not only does the patient understand what their responsibilities are going to be, you can also talk to them about what their options are to meet those responsibilities.
No, I agree. And when you say pre-registration, you're meaning before they come into the office.
Yes, exactly. So, if you have when you once you schedule your appointment, then it's almost like an appointment reminder type thing where we have a few days before that we're talking to our patients, and that's when we're having conversations to make sure we're getting the most updated insurance information and having those financial conversations in a safe and confidential setting.
Right. And I know it's tough when, patients come in emergently, those exceptions to the rule, you still have to have it, in the office setting. But, to Lorraine's point, you also want to make sure that you have some kind of an area maybe you could go to talk to the patient, even if it's a cubicle or something, because there are HIPAA concerns there as well. Now, I wanted to move forward a little bit with, again, the patient responsibility and what is old school versus what is available now. You and I have been doing this a long time. I'm in my 40th year of healthcare. I've been around forever. And so, yeah,
I'm not
just
far behind you, Terry.
just aged myself. Oh my goodness. But I mean, I did pegboard systems. I don't know if you did. Remember those where you press down? I don't know if you had to deal with that. That's non-computer, by the way. We
Yeah,
typed our claims.
I don't know that I go back that far, but
Yeah, it's
I
pretty bad. It
used
was
Epic
pretty.
on a DOS system.
Yeah,
So,
I was
yeah.
pegboard and all the paperwork and typing claims and everything. But back then, when patients wanted to be put on a payment plan and paid over time, the clinics would take on that burden, and then patients they're really good at the beginning. For the first 3 months, they stick to their payment plan of $50 a month. And then all of a sudden you see them skip a month if it's Christmas, or the next time you get like $25, then you get a $10, and then all of a sudden you can't find them. And so, and that's why I was wondering, how do you feel about, some of these third-party financing companies to manage payment plans? I actually like that there's that option.
Yeah, I love it. And I've seen it be transformative for practices.
Oh, good.
Um, I've worked with practices that have implemented this, and it's really been transformative for their cash flow. So it's really beneficial for the practice because the practice then gets immediate payment and, you know, keeps that cash flow going. It also helps to reduce the administrative burden on the staff. So overall, it's saving you money in your practice because you don't have the administrative burden of your staff trying to keep track of when these things are due and if they're being paid. The patients also appreciate it too because it gives them flexible options, but it also gives them a set schedule. So they're dealing with a company that's all they do is to track these things. And all they do is to, like any other payment arrangement that we're making, like our car payment,
Right,
it's their
right.
monthly bill and they know exactly what to expect. And we as the practice have already received our payment from it.
Yeah, well, actually, you brought
I
up a good point. I don't think a lot of providers realize that when you partner with a third-party financing company, you get a lump sum up front. And then they
Yep.
go after the patient for what their share of cost is. They make the payment arrangements. The patient repays the finance company over an agreed upon period of time and they outline their responsibility, right?
Yes,
It's
exactly,
not like
exactly.
collections where they say, well, we'll give you your money if we ever get it.
Right, exactly. No, normally you get paid from the finance company in about a week or so. So
Yeah,
you get that money up front. It's actually you get paid from the finance company quicker than you'll get paid from a regular insurance claim. So yeah, it can be really, really beneficial. I've seen it a lot, do a lot of good in our rural areas, our critical access hospitals, our rural health clinics, those people that are really struggling for cash flow. It can be a game changer.
that's nice. That's nice. Yeah, it was because I remember, again, back in the day, 80s and 90s, where the only way to pay your bill was by check through mail, through a statement you got, or coming into the office with a check. They practices, I don't know if our listeners knew this, they didn't always take credit cards. They're like, no, that's too expensive. And there was a time back in the day where you couldn't pay medical by credit card. Now Venmo and Zelle, and then
Yeah, there's so many
Sears
options.
credit
Yeah.
card. I mean, you have so many options. Somebody said I can pay with my McDonald's app. No, you can't. But I'm just saying there's so many options now to be able to pay your bills that taking that burden off you from an out-of-pocket expense of the patient. Well, and it also, I think one thing that those third-party financing companies do, based on what I've seen, is they help you to keep your relationship with the patient clinical and not
Yes.
have to deal with the financial feelings about that can be unfortunately negative sometimes.
Exactly. And it makes it more affordable and therefore accessible to our patients. It also helps to build trust with the patients because there's something that's set in stone that the financial burden is going to be done by these people over here. We're here to take care of you as a patient.
Right. Now I have a question for you. This is something that's come up with some of my clients lately, and this has been, oh my gosh, kind of a nightmare. And I'm talking about coordination of benefits. And I just mention it because I think some patients, well, a lot of patients, and I think, I understand their position. They think because they have dual coverage, they have 100% coverage. And that's not always the case because a lot of times the secondary insurance says, no, the primary already paid enough and we don't even allow as much as they did. Or it's hard to figure out who is the primary, or they end up paying the patient, which really is a nightmare. How do you deal, I just brought up that point. How do you deal with, from a client perspective, what do you tell clients to say, hey, the patient got our payment, we can't get it back? What do you do?
Yeah, that's a tough one. It really is because, once that payment goes to the patient, you have no, like, you can chase that patient down, but they're not going to come back to you to turn that money over to you, especially if it's a significant payment. So there again, I think it becomes really important in the pre-registration process to make sure that we're talking to that patient and we're using our knowledge to help that patient with the coordination of benefits up front and letting them know what their benefits are. We always recommend that a verification of benefits is done. Doing prior eligibility is not the same thing as verification of benefits.
Right.
So on our prior eligibility, all we're doing is making sure that that insurance is active for that date of service. But having a verification of benefits done in that pre-reg process and making it part of that conversation with the patient is essential to good financial health for any practice.
Right. And you have to also, when you're trying to verify benefits, again, different than eligibility, you're also doing a lot of pre-anticipatory, looking to see, okay, well, we know we
Yes.
do echoes or EKGs or this kind of testing in our office or labs, and we want to make sure that's all covered. So the patient has a realistic
Yeah.
view of what will come out of their pocket.
Yeah,
So,
absolutely. Especially if you're dealing with mental health benefits,
all right.
which can be different. So, if we have a patient coming into, say, coming into a clinic and we have both mental health and primary care in our clinic, the benefits are going to be different on each side. So we
Right.
want to make sure that we're looking at what the benefit covered is there, or even a PT practice can be different than what the benefits are on our regular medical coverage. So
Yeah.
we want to make sure that we're looking at that and letting patients know up front, because an informed patient is going to be much more apt to follow through on these things.
Well, you just made a comment too that I'm finding that a lot of practices don't understand, and I think this is important for our listeners. They try to, sometimes I'm seeing they're leaving the, not just the eligibility, but the verification of services and what's covered to the patient instead of doing their due diligence on their own. That's not okay because patients want to
No,
get in and they'll tell you anything. So,
exactly.
bless their heart,
Exactly.
you feel
Yeah.
bad, but they will tell you, well, no, I have coverage and I've done this. You have to verify. You have to verify.
100%. And a lot of times the patients don't understand, the
Right.
patients aren't in our chair and they don't have our training. So they they're looking at something and it doesn't make sense to them. We do a lot of training with different staffs when we go into practices as consultants. We help these the staff to understand these things. The patient doesn't have anybody helping them to understand these things. So that's why, these things become so important, because if you don't do these things, the revenue leakage is going to bury you.
Yeah. Well, and I mean it's similar to me of what's going on with telehealth right now. Just I gave a webinar yesterday for the NSCHBC and people say, well, it's on the approved telehealth list. No, they cover that. And I'm like, okay, but right now with the government shutdown, you don't have the geographic location. You can't be in your home. And they're
Right,
just like, what are you talking
exactly.
about? It's covered. No, it's covered, but it's not. You haven't met the other eligibility part, as we were just talking about. You're not
Yeah,
eligible for it,
exactly.
so it's hard sometimes to navigate through the rules because half may be true, but the other half not so much. Um,
Right.
but now, how does the No Surprise Act come into play? Because I know that's been a really big deal for practices. There's the $400 threshold that, patients have kind of a cap, if you will, of not having to pay more than that if they get a surprise, if they weren't told or they didn't give authorization. And now that's mostly for out of network, but there are also some in-network situations in the hospital that were extended during the last administration. Do you find that you have to deal with that at all?
Yeah, we deal a lot with the No Surprise Act. We want to make sure that our practices are being compliant with the No Surprise Act, that they have informed their patients. It needs to be in writing as part of your financial agreement. It also needs to be posted. So there has to be written notices that are provided. You need to have written notices posted in your office and also online for any website. So it's really important that it's posted there as well. I've worked with practices that have come in that have gotten caught not having this posted correctly, and they've been fined. So we really want to make sure that those things are done and being done correctly. The No Surprise Act, it protects the patient from surprise billing. So we see this a lot in emergency services and in air ambulance services. But then again, just as you said, there's also out of network providers. So, with the No Surprise Act, the patient is entitled to a good faith estimate. And that good faith estimate would be based on what your fees are, and then you need to give it to them within $400. So if it goes more than $400, then the patient can come back and they can fight any additional charges.
Right.
So the good faith estimate needs to be provided in writing to the patient. It can be mailed or it can be by email. But however you do it in your practice, you need to be consistent and you need to have it as part of your financial policy for best practice.
Right. And it protects the patient, not necessarily the provider, but it does protect you in the fact that it forces you to have that explanation, have that discussion, and make sure that you have financial agreements in place. Because, these agreements, they clarify who's responsible for payment, co-pays, deductibles, balances not covered by insurance. And it really helps ensure, payment by defining the terms, and making sure that providers do offer payment plans, whether it be through third-party financing companies or however you're doing this from an outside company. But you need to make sure that everyone's focused on insurance collections, insurance billing, insurance. But when you let things go like the patient's out of pocket, their share of cost in those conversations, I believe that can not just add to, as you put it, the leakage in the revenue cycle department, but also the relationship with the patient. And without patients, we don't have jobs. So
100%. It's all about building trust with our patients. Our
right.
patients need to trust us as a whole practice. And that means everybody who has interaction with the patient. So, we need to treat our patients as people, just as we want to be treated as people. So put yourself in their shoes, make sure that they're getting the information that they need and that they understand that. And then that also takes us back to it not escalating to them going into a room with a physician and discussing these things.
Right. And it also, think about this too. Patients sometimes get embarrassed if they don't know what they still owe, or worried, and so they may not come in for their visit, or they may cancel their appointments, and just because they don't want to deal with it, and they don't want to be attacked at the front desk for money if they know that they haven't paid in a while. So having, again, this accountability, this payment process, these conversations, these financial workflows in place, I guess that's the best way to describe it, not only helps the patient keep their health in check, their financial health as well.
Absolutely.
All right, great.
Absolutely.
Well, Laureen, I'd love to thank you for being on the podcast today. I hope to have you again soon, and we appreciate your insights in this important topic to the business of medicine.
Well, thank you so much for having me, Terry. It is a pleasure and an honor.
Oh, it was great to have you. You can find the contact information for Laureen at NSCHBC.org under Find the Consultant tab. And we actually have a new webinar or website up now. It looks pretty nice. Type in Laureen's first name, Laureen, and there she is. You can also type in Murphy if you want under her last name, and you'll find her as well. As a reminder, NSCHBC.org website offers monthly free webinars on a variety of topics, as well as a quarterly Medicare webinar update for all educational offerings. Go to the NSCHBC.org and click on Upcoming Education tab. You'll also find this podcast there. Also look for our next Consultants Retreat Conference, January 8th through 9th, 2026 in Charlotte Harbor, Florida. You will find this also under the Education tab for upcoming events on our website. That's it for me today, everyone. Please join me next month when we once again bring you current and important topics in the business of medicine. Everyone, make it a great day, a great rest of your month, and thank you for listening to the award-winning NSCHBC Edge podcast. I'm Terry Fletcher.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.